But this is going to be like a review. It's so wonderful to come and give this talk because when we first started, I gave this talk. It was like, what's happening? What's coming? Please wait for it. It's coming. All of this stuff is in the clinic now. It's becoming mainstream part of everybody's talk. And we're currently taking all of this stuff and moving it on to other solid tumors. And as we've grown together, the Angeles Clinic has grown. We've just opened our reinvigorated, redone clinic, and next year hopefully we'll all be together in the clinic space for conference, the conference area, and we'll go from there. This is usually where I wait to give Dr. Ferries his coffee as he pulls in the mornings, but it's been great. In 10 years what we've done, and I try to keep it relevant. I have 2 young kids, and they try to keep me on what's hip and what's on. Dr. Davies, wherever you are, I want to tell you there's a new poop emoji. It's rainbow poop emoji. Okay, that's for your talks. You're welcome. And then the other thing is, if you guys are on the Instagram or on the Twitter or on the Facebook, I'm on all 3. It's the 10-year challenge, and I just want to tell you, the best 10-year challenge I've seen is a 10-year challenge that's come from melanoma. And those are survivals in melanoma that have gone from 5-year survivals of under 10% to being over 40% and continuing to grow. So on the whole theme of obesity and gaining and taking on, our clinics are getting bigger and our patients are doing better and moving forward. And one of those ways that we've seen that is, this is data. I love anti-CTLA-4 ipilimumab, whereas all these other drugs that are coming out, the granddaddy of them all, is Yervoy here. And it shows that, not only do we get this benefit, but this benefit is going on and out and out. And what we're going to be dealing with now is long-term data, long-term survival. We'll bring more to give to you. And by the way, one of the notes I've always made is to mess up Dr. Davies' slides, and mine will all be the right size now. So here's the long term. And you've heard about all of the drugs that have come out and are available. You can basically take this out and say the increasing complexity of any solid tumor, and this data is going to liquid tumors, et cetera. And the questions we now have are what to do when you get a therapy and then you have new things show up. So what's going on with local regional recurrence is our surgical oncologists coming out now and not being told, salvage this horrific growth, but we're finding out that there are areas where tumors will grow where the rest of the body is responding. And those tissues are now being taken out or radiated and looked at, and it's a good plug for our tissue bank that we're opening and moving forward with at Angeles under Dr. Ferry's guidance. Also the understanding of trying to know more in a neoadjuvant fashion and being able to tailor the next trials for not just for all patients, but individually for every single patient. We've got drugs that have higher response rates where we were talking about 10 to 20%, now 30, 40, 60 in combinations. But also going back and trying to understand more predictively what to do. But new problems come, and that is, it's a good thing you heard the adjuvant therapy experience from Dr. Ganji. But what do we do now when the drugs that we had put aside for those patients who had a distant recurrence have already been utilized in the adjuvant setting right after surgery? Where do we go? Who do we retreat, and what do we do? And how long do we wait before giving you the same drug and seeing if it works, or is it time to change? So I'm going to sort of go over some of the stuff you've seen already, but really talk about the trials that are going to answer these questions. So it's not just PD-1 and CTLA-4. There's lots of targeted checkpoints, as they are, that where we block the inhibition or where we turn up the activation or hit the gas pedal. So many years ago, I thought that this was a dream, but all of these drugs are currently in clinical trials, not just in the initial, but in the adjuvant setting. And when we used to talk about, well, we're going to do the trial and show you the data is here, where we know that we have not just found a new therapy, but we haven't gotten rid of the therapies that have shown that they've worked before. This is data that comes from that KEYNOTE-6 study, where we randomized between anti-CTLA-4 ipilimumab and anti-PD-1, but we looked at those patients where PD-1 didn't work and found out that we can still use the anti-CTLA-4 later. And not only can we do that, but we can put these drugs in a way where the toxicity is not the rate-limiting step, where we can get higher dosages, where we can do better. And these are some of the new ways that we are rebranding and reintroducing those drugs, whether they, like a normal immune checkpoint inhibitor, but having them, having a way where we can put proteins on it so that it's only activated in the tumor, not in your colon or in your skin, so the side effects are minimized. Antibody drug conjugates, where the antibody goes directly to the tumor and it has a drug at the end, sort of like a heat-seeking missile or a Molotov cocktail. Bispecifics that bring two things together. If your immune system is not there to recognize your tumor and to initiate that contact, you remember Dr. Daniel's real video that I'm going to steal from my talks about the T cell eating the tumor. Well, bringing the T cell together, sort of like a matchmaker. So I call these Yenta antibodies, and they bring them together. And then CAR T cells that reinvigorate the T cell immune response. And we have that. This is from a lovely guy who invites us up to Italy, where we get our suits and our Italian food. Paulo Asierto looked at this is the LAG-3 antibody, and this is what we showed you here. Where is it? Right here. If we can combine, what if we have patients who've seen PD-1, and this looked at not only giving the LAG-3 antibody with the PD-1 at a time where that drug is not working as well, but also taking your tissue and seeing if that's the right drug. If there's an increase of LAG-3 in your tissue, that tells us that this drug may work better. And you can see here, if the LAG-3 staining was greater than 1%, 45% of patients benefited, if not only 24% of patients. So more personalized therapy, and I'm waiting to make a slide because it all comes back to fashion. It's like bespoke immunotherapy, where you show up and you say, I may be obese, I'm not obese, but make something that's a 44 long. And for you, it's maybe a 38 or whatever, but it's bespoke. It's made for you, what your tumor, what your microbiome, what everything else shows, in order to get not only the best treatment up front, but to know where to go if up front is not the most. This is a great idea because we can now look at other things in the tumor microenvironment, and this cartoon shows, an inactive T cell, myeloid cells that work to increase inflammatory cytokines that leads to immunosuppression and tumor growth, and macrophages that are immune inhibitory. And what we've seen is that there's a compound, Siglec-15, that's upregulated in this setting. And what we've made are antibodies to this. And you say to yourself, well, okay, great. Where does this fit in? Well, preclinically, we found, and let me just decipher this for you. We found that those patients whose PD-L1 levels are low, those who we know are going to have a lower chance of responding to these new PD-1 antibodies, guess what? Their Siglec-15 is high. So that drug is now being tailored to those patients with lower levels, and we're looking at it going forward. In LA, if you want to get people to come to a talk, if you want to have your colleagues come, if you want to have everyone show up, you say, I'm going to talk about injectables. And these injectables are not Botox or Restylane, but they can be just as good. Every once in a while, you see some blonde walking out. She's come to the wrong talk. But these injectables are phenomenal because they can do something. Not only can they help together, but they can prime the immune system. And Dr. Daniels talked about this, but we have multiple injectables, and this is not a new thought. Way back when we only had interleukin-2, which was one of the first approved therapy for melanoma, metastatic melanoma, we were injecting IL-2 all the time. And Dr. Ferries comes from a lineage of people who injected BCG that's killed tuberculin to create an immune response. We've just made it new. We've rebranded it, which is another LA thing to do. Injectables, rebranding, et cetera. And we have multiple, it's not, you don't need to know how this works, but Toll-like receptor 9 agonists, they create an immune active environment. And what we've seen is not just that it works initially in combination with PD-1, but this data is in patients who failed PD-1. And what we've taken is these injectables and combined them with the drug that we moved from early to late, ipilimumab, and it's showing that you can get double response rates, double the amount of patients can benefit. And what that means is in the long term, we're finding out. And then when you bring it in the first line and combine it, we're seeing response rates that are going to be greater than just a single agent. And while we sit here, these trials have been done. The data is cooking, and by next year we can tell you if giving it early or giving it late is better, if it's helping patients do better initially or later. This is all coming forward. These therapies promote not just response locally, where they're injected, but they distantly, that's been presented, but also helps us another shameless plug for our tissue bank. When we inject, we can also get biopsies and see what's going on. So a dynamic evaluation of your tumor, of a patient and how things are going and how to make decisions. Because just like I'm not the same person that I was 10 years ago when I first started, I'd like to think better, but grayer, the tumors are not the same as things go on. And not only are we just injecting locally, but now through collaborations with our interventional radiologists, we can take these drugs and inject them directly into tumors in other locales. Because for melanoma, not everyone has something that's readily available. For lung cancer, 0. But you can take them and inject them into liver tumors, into tumors anywhere in the body where you can get a needle. So maybe we can take those plastic surgeons and utilize them to inject tumor instead of inject fat. We talked about sting, but it's a thought that's there for almost every solid tumor. And we're seeing responses not just in melanoma, head and neck cancer, et cetera. Your work and our work together has taken this immune therapy paradigm and made it standard for first-line therapy for lung cancer and head and neck cancer and lymphomas, et cetera. So I'll go through that. And we're also finding out that maybe something you utilized for a time and it stopped working. You can come back down the road and see responses. And these are for targeted agents, the BRAF-MEK pathway, that mutation. There is data to show that if you're running out of options, you've had someone who's been targeting that mutation in the past, it stopped working, you let some time pass, you can clearly reinitiate a response and get some benefit going forward. And that's important because we're now not just looking for one mutation. We're sequencing all tumors, looking for mutations that exist where we can get some information from other solid tumors, whether it is melanomas that have ALK mutations, mutations that exist in lung cancer where there are standard drugs that help patients with lung cancer do better. Can they help the melanoma patients? And we have trials for that. It works conversely also. The BRAF mutation exists in about 8% of all solid tumors. And happily, I have a patient with ovarian cancer who has all of her tumors respond to BRAF-MEK therapy. So it works both ways. Mutational load is a way where we get these neoantigens. These are proteins on tumors that are different, that the immune system recognizes in a better fashion. And all of these graphs, the cliff notes for these graphs are that you do better and you respond better if you have more mutations. So how can we bring those to the fore and allow you to do better? And this is the essence of bespoke immunotherapy. And these are trials that we are running at Angeles and throughout for all solid tumors, where we take tissue samples from a patient, we take blood, and we do the sequencing. What are the mutations and type for this patient? We design a vaccine. Just like you get vaccinated against measles by injecting proteins that allow your immune system to recognize measles as foreign and attack it if you get infected, same way for your tumor. And then we manufacture that vaccine, we administer it to patients, and not just administer it solely, but administer it with other immune therapies like PD-1. And all it says is that allows the immune system to recognize these tumors in a better fashion. And at this time, not only are we looking at this paradigm in metastatic tumors, we'll be opening a trial looking at it in the adjuvant setting. You know, that tissue that they were taking out before and sending to stay in some pathology lab will be used to make a vaccine where these patients with stage 3 locally advanced disease will get the vaccine plus PD-1, building upon what Dr. Ganji talked about in order to get better outcomes. Adoptive T-cell therapy was presented, and this is where we take your tumor, take out the T-cells, and we increase them to billions, and then we reinfuse them into the patient. And you saw where we can get responses. But what I find the most amazing about this trial that Dr. Daniels and I and others are running is that it allows us, even more me, as a community center, to offer something that would take a manufacturing area, it would take huge resource, and offer it to our patients, because there's a central area that can do this for us. And if you look, this is the data they presented about the 38 or 40% of patients that had a benefit and a response. This line here is best overall response on prior anti-PD-1 therapy. And the majority, over 80% of these patients, were patients that never responded to PD-1 therapy. So one of the things I hear from patients are, what if this doesn't work? Because all I hear about is this is the only thing, but it's not true. And not only are we bringing these to the fore, but we're combining them together and moving forward. So we're looking to enhance our immune system and T-cell activity. Not only are we doing initial things to induce tumor cell destruction, that's the injectables. And then we're giving checkpoint blockade, that's the ipilimumab and the pembrolizumab and the nivolumab. But we can fix that more. We can identify the neoantigens by making the vaccine and providing combination with checkpoint blockade, which we've talked about. And then we can also we can expand and provide checkpoint through T-cell product like the adoptive T-cell therapy. And guess what? The next thing is to put all of this together. Hey, I'm going to give you this and a vaccine and inject. And as we first started talking about a single drug, and now we're moving on to combinations and triplets, there will be times where we will give not one, not two, not three, but more and more. And you get a vaccine, and you get a vaccine, and you get a vaccine, and everyone can get a vaccine. This is the aforementioned Yenta antibody, and bispecifics are coming into the fore. One side targets the T cell, the other side targets the cancer cell like this. It brings them together, and instead of creating a lovely relationship, it creates a toxic relationship where we kill the T cell itself. We kill the cancer cell itself. And what's the proof of principle here? Well, this drug has been combined with checkpoint and is now orphan designation by the FDA for another type of melanoma, ocular melanoma. One of those melanomas that's really never been immune sensitive has a benefit from this type of therapy where 1 year outcomes have doubled, unbelievably and amazingly. We've also brought together the two warring clans. This is great as Game of Thrones is about to end. There are a group of people who believe in targeted agents, and there are a group of people who believe in immunotherapy, and when we get together, we say, well, we should do this one first, and we should do that one second. But what we've learned is by combining them, we may be able to, enhance tumor death, activate the T cells, and then prime with the immunotherapy together. So MAP kinase inhibition, which is targeting BRAF and that pathway, can really create an environment where immune checkpoint blockade can work well with the targeted therapy. Not to be lost, high-dose IL-2, which thankfully most of you are not familiar with. It used to be the initial talk we had is being fixed, and there are new drugs that stimulate that pathway, and we're looking at combinations there. The microbiome you've heard a lot about, but one of the things that was difficult is in the past bringing MD Anderson and someone like Dr. Davies, where he says, well, I have 6 people working on this, and this has come through to one trial. But this trial that's going forward with the Parker it's multinational, it's got many sites, and it's open at the Angeles, where we've shown, not just by doing this in mice, but doing it in humans that we may get better responses. And thankfully, ours is a pill trial, but there are others who are going to the further extremes to increase benefit. Almost, it was unbelievable, but there's a guy named Hassan Zarur who's in Pittsburgh who has identified a great gut microbiome and is doing fecal transplants in patients to see if they can get a better and an earlier benefit. And just as we've begun and we've talked about injectables in melanoma, and we've talked about the bespoke immunotherapy, the other thing that I want to talk about is the exquisite responder. And we have some of those people here, where my belief and our belief is that it might not be at this time that we need to do 900 patient trials, 600 patient trials. But we need to do small trials where we're grabbing your saliva and your poop and your skin and your tumor and following. And when we find that one person who has the unbelievable response, the one person that after 1 or 2 doses has everything go away and stay away, we go back and interrogate all of that to find out this exquisite responder, and then utilize that as the bouncer for which patients come onto which therapy. And so instead of just having everyone go onto one trial, we can identify them before as blue or green or yellow, and maybe the yellow person is the person that goes on to that initial trial that I showed you with the LAG-3 and the PD-1, whereas the blue person is the person that needs to go on to poop-targeted therapy and PD-1, and then give them the right therapy and get those response rates higher. Because one of the other things we are here in LA and at the Angeles Clinic is greedy. We want better. We're not satisfied with saying that in 10 years we've done great. So I want to come back and the 15-year challenge look phenomenal. And so that's where we're going. So this is our plans to go forward, the tissue bank, the idea to look at tumor blood, microbiome, oral, and understand when to treat, get all of this stuff early on treatment also in a progression and move forward. We've shown that this can help us. I mean, it's just looking at the circulating DNA in blood, and this is data that's come from Melanoma Institute of Australia and others, where you look at the baseline blood samples in our adjuvant patients and see what mutations are in the blood, do surgery, look again at the blood and see what's happened. And those patients where the mutations go down, you know that they they do better postoperatively if their circulating tumor DNA goes down. So it can give us an idea about how aggressive to be and who doesn't need therapy, because there is some toxicity to this therapy. So as we come to the end, it's just like an amazing convergence of not just collaborators from outside of LA, and not just from surgical and radiation oncologists, but also from newer friends and this affiliation with Cedars-Sinai and AIM at Melanoma, where we've all come together sort of, as my son would say, as like the Avengers working against melanoma.